Welcome to segment 2 of the CME program, Investigator Insights into HCV. We are going to discuss in this segment, in the HCV HIV co-infection, risks and future treatment options, current treatment options for hepatitis C. Daniel, we've been treating HCV HIV co-infection for many, many years. Typically they have genotype 1, although there are co-infected patients that have genotype 2 and 3, just as there is in the mono-infected population. Up until the advent of the direct-acting antiviral agents for HCV, what have been the challenges in treating HCV HIV co-infection with pegylated interferon and alpha and ribavirin in the past?
Yeah, the treatment success in HIV-infected patients in genotype 1 has really been grim. A quarter of people being cured, a year-long therapy plagued by the kind of onerous side effects of interferon ribavirin. It's led many of our patients to simply refuse to be treated, not talk about it, and so the world did somewhat change for us with the FDA approval of telaprevir and boceprevir in the summer of 2011. That although the HIV-infected patients weren't studied prior to the approval, they were studied subsequently, and that gave us some guidance and some PK studies looking at drug-drug interaction with the antiretrovirals. So what we found from those was that boceprevir really couldn't be used with most of the antiretrovirals, and as a result, I think was used not very often. There were some other issues about boceprevir, perhaps, and the telaprevir at Mount Sinai and other places ended up being a little more commonly used. And you could use it with a couple of more antiretrovirals. You could use it with atazanavir and efavirenz and raltegravir.
Well, what were exactly the issues? So the main issue that we were concerned about was drug-drug interactions. Yeah. I mean, what were the drug-drug interactions? I mean, which classes of drugs were interacting, right, and what would be the potential consequence if we just used telaprevir, for instance, in this population?
Right. So the hepatitis C protease inhibitors, interestingly enough, seem to interact a lot like the HIV protease inhibitors, but in what turned out to be in unpredictable ways. And the Vertex folks did a good job early on showing that while atazanavir levels and the telaprevir levels did not change significantly in a way to make either of them not viable, darunavir and one of our other favorite protease inhibitors, for instance, levels could either be much lower for telaprevir or much higher for telaprevir, much lower for darunavir, much higher for darunavir, or for the protease inhibitors. And so this unpredictability turned out to be a really problem, and it showed that it was not a good idea to just guess and say we do one in a class. So atazanavir turned out to be okay. Efavirenz increased the metabolism of telaprevir, so we had to use 50% higher dose of telaprevir, but that turned out to work, that the efavirenz dose didn't change. The raltegravir is fairly neutral in that. And so what you had was unpredictable drug-drug interactions. Boceprevir really turned out none of the protease inhibitors were safe. Efavirenz probably not, and so it really made it too hard to use. But many other problems with telaprevir. So you took this onerous PEG-riba treatment with lots of ribavirins and nausea and malaise, and you gave them telaprevir, which you had to have with 20 grams of fat. Initially, we had to be dosed Q8. It was almost the old Indinavir days of Q8, not TID, Q8, with 20 grams of fat with each meal because you needed that for absorption. They got a rash, particularly bad in our patients, really itchy rectums. That's very, very uncomfortable. And it turned out something that wasn't seen in the early studies, that it made, in some patients got terribly anemic, almost explosively anemic, even within the first 4 weeks of treatment. And so you had a much higher pill burden, significantly increased side effects on top of this already onerous thing. Didn't shorten treatment apparently at first, although later we found we could have shortened treatment a little bit with response-guided therapy. So you had this much more difficult treatment. But the good news was, it turns out that the SVR rates for HIV-infected patients in this trial and in real life were every bit as good as they were for patients without HIV infection. And what this was sort of the beginning glimmer of, and we'll discuss the data and how this has really been true with the potent drugs. This was a fairly potent drug, that it makes HIV infection now no longer this large decrement in treatment response that it had been. It had been up there, or maybe even worse, than diabetes and obesity and other things that caused lower SVR rates. HIV was really prominently one of them. With these newer drugs, it takes HIV somewhat off the table. And what that means is we should, again, talk to patients and docs who have sort of gotten hopeless about Hep C treatment and say, we've got drugs now that really will work to cure our patients. So the SVR rate in the trial that was done was 75% for HIV infected patients, and it was really basically the same as the study without HIV infection and published in the New England Journal.
So from a practical standpoint, because you have an extensive experience in treating patients with the first generation protease inhibitors with HCV HIV co-infection, and there wasn't an FDA approval for this indication. The company couldn't promote the drug for this patient population, and consequently, a lot of providers didn't treat patients with HCV HIV co-infection. But I know you did, and from a practical standpoint, did you have any difficulties making sure that patients were on the correct HIV protease inhibitor regimen, or really was that a seamless transition for you?
Well, a little of both. One of the real advantages of being an HIV doc and treating the hepatitis C patients come to me, and I would take a very careful antiretroviral history. While we may not be very well educated on the liver disease aspect, it really helped in the thinking about that. And so I looked very carefully and did not want to mess up anybody's HIV treatment, and so I would examine their antiretrovirals carefully. And so there were people who were on their first regimen, and darunavir was chosen, and you could switch them to atazanavir for, it only really had to be 12 weeks. Telaprevir was 12 weeks, and you could always switch back once the telaprevir dosing was done. Some people could get raltegravir. And so I was actually quite successful in getting patients switched. The ones who were on true salvage, the ones who were on the darunavir, travir, regimens, probably not a good idea. So I actually found that the majority of patients could be safely switched. You really only needed to do it for a short period of time.
So patients that couldn't be switched, and you identified them perhaps as people that were on salvage regimens, and regimens where you really didn't want to tamper with a regimen where there might not be other options. But ones that could be switched, you would switch them, and then you would keep them on the other on the new regimen for the 3-month course of telaprevir. And then you would switch them back to the regimen they were on previously?
Some liked it a lot, and so decided to stay. And but if there were troubles, then you really only had to get through that time.
Right.
And it's a small point, but interferon is actually a weak anti-HIV drug, maybe a half a log. And if we do these from the pre-antiretroviral days. And so some suggested that it might help if you didn't have the most potent agent. I was reluctant to think of it that way, but nonetheless, it is a reasonable addition when you're treating with interferon. Some people think of it as, oh, it's going to be dangerous for immunity. Actually, is actually helpful for the HIV.
So in practice then, so from a practical standpoint, in appropriate patients, you didn't have trouble switching them to an acceptable protease inhibitor HIV regimen so that it would not cause harm with telaprevir. Right. From a real-life efficacy standpoint, what did you see in your practice with efficacy rates with the combination regimen with the first-generation protease inhibitors?
Well, not surprisingly, the clinical trials are always somewhat better. They manage to find the healthiest people in the world. I don't know how that quite happened, but our SVR, so the real-world SVR rate was compiled by one of my colleagues, Andrea Branch, at the Mount Sinai experience, and it was closer to 50% or so, but they actually did better than the HIV uninfected patients. We didn't have a large enough group to have a large statistical significance on that, but it was an interesting and surprising result. Many interpretations possible. One is our patients were just better at taking medications. They'd been taking complex medications before. They were better at enduring side effects. We don't know, but it was interesting and again heartening that while the success rate wasn't as good as in the clinical trials, it was still just as good, we could say, as the patients who didn't have HIV infection. Further heartening us to say we need to get treatment for these patients.
So I guess what was heartening about this experience that you and other centers have had with treating the HCV HIV co-infected population was that the direct-acting antiviral agents seem to have excellent efficacy in this patient population, and they didn't seem to have extra safety signals that we were surprised about. I mean, they had safety signals certainly, but they were the same ones that we've observed in the mono-infected population.
Pretty much. They didn't get worse rash, for instance.
So the only downside was, well, two. One was that the HCV HIV co-infected population seems to not be studied frequently up front, so the FDA doesn't approve it for that indication. And the other downside was the drug-drug interactions that we would hope to ameliorate with future regimens.
Right, right. In fact, the lesson learned from that was now, as you know, and we're going to talk about, the studies in HIV-infected patients are happening prior to approval, so we have data and in some case, actual labeled indication for HIV-infected patients when the drugs are approved originally.
So that's an excellent segue because in recent months, there have been 2 new approvals of direct-acting antiviral agents in the United States for treatment of patients with hepatitis C. One is Sofosbuvir, that was only approved for genotype 1 patients, and the other was Sofosbuvir, that was approved for treatment of HCV patients with genotypes 1, 2, 3, or 4. So let's talk about them each a little bit. Now, Sofosbuvir is colloquially known as a second-generation protease inhibitor. The advantages are that it is a 1-pill, once-a-day regimen. It's taken with food, but not with 20 grams of fat like telaprevir was. And the safety profile in the mono-infected patient population, with Sofosbuvir itself at least, is excellent. Now, Sofosbuvir was approved in combination with Pegylated interferon alpha and ribavirin, so it's a triple therapy regimen again. One of the advantages is this was a fixed treatment duration regimen. There isn't a response-guided paradigm that we had with telaprevir and boceprevir, meaning that treatment-naive and relapse patients get 24 weeks of total therapy, period. It doesn't matter about the robustness of the virologic response early on therapy. You don't have to make that decision. 12 weeks of triple therapy, followed by 12 weeks of peg-riba. And then in the partial or null responders to peg and ribavirin, those patients got 48 weeks of therapy, 12 weeks of triple and 36 weeks of peg-riba to follow. Now, this is one of the medications that was not examined in the HCV HIV co-infected population. So do you see a role, Daniel, with Pegylated interferon ribavirin and Sofosbuvir in the HCV HIV co-infected population?
Now, it's a tricky one because unfortunately the drug-drug interactions of Sofosbuvir are more like what it was with boceprevir. You're really restricted to the integrase inhibitors, raltegravir and dolutegravir, but probably not the quad pill because we don't know what cobicistat is going to do, and then to rilpivirine. No HIV protease inhibitors. So while it's a great relief to not have an itchy rectum and not have the terrible anemia, not have to take all those pills with all the food, I think that the usefulness will be limited, and certainly the desire to use that much interferon is going to further limit the usefulness of this in our patients. But as we'll come to, I want to talk about the possibility, the very attractive possibility of using it in an interferon-free regimen is going to make this something that we will actually be trying to use on some of our patients.
So let's move then to the approval of Sofosbuvir. Now, Sofosbuvir is a first-in-class direct-acting antiviral agent, at least in terms of approval. This is an NS5B polymerase inhibitor, a nucleotide polymerase inhibitor, and this medication was approved not only for HCV mono-infected patients, but for HCV HIV co-infected patients, because there was a trial that we're going to comment upon in a few minutes that examined this population before FDA approval for once. Now, as you know, and the listening audience needs to learn as well, the FDA approval isn't always the way that we use it in practice. HCV HIV co-infected patients with genotypes 1, 2, 3, and 4 are approved as follows. Genotype 1 and 4 patients, whether they're treatment naive or experienced, the actual FDA approval indication is for Pegylated interferon, ribavirin, and Sofosbuvir for 12 weeks and 12 weeks only. Not 24 weeks, not 48 weeks. It's not response guided. It's a fixed treatment duration. So it's very, very easy. And by the way, I didn't mention Sofosbuvir is 1 pill once a day. And really there has essentially been no safety signal identified with this product. But that's how it's approved. Triple therapy, 12 weeks for genotype 1 and 4, including mono-infected patients and co-infected patients. Now, genotype 2 patients, the approval with HCV HIV or mono-infected patients, treatment naive or treatment experienced, is for 12 weeks Sofosbuvir and ribavirin alone. No interferon. First interferon-free regimen ever approved for hepatitis C, in history. Genotype 3, which is a little more cranky, also they approved an interferon-free regimen for HCV HIV patients or mono-infected patients, treatment naive or treatment experienced, but it was for 24 weeks, Sofosbuvir and ribavirin. So that's the FDA approval indication. Now, maybe, Daniel, you'd like to comment a little bit on the study that was done called the Photon 1 study that actually examined the use of some of these medications in the co-infected population, because the study was done a little bit differently, at least for genotype 1, than how the medication was approved.
Yeah, that gave some very important information, some good insight. So what that study was is really interferon-free completely. So that was looking at, for the genotype 1, we were talking about 24 weeks with ribavirin. For most of our talks, if we forget to mention ribavirin, it's usually in there. So the SVR rate was 76%, which, showing how the new standards are, I'm thinking of that as not very good. But 76% is every bit as good. It is the best study that we've had with a year of interferon and ribavirin. So this was 1 pill a day plus ribavirin for 24 weeks, and which is actually fairly astonishing. So that gives us some pretty good evidence that we can use that for people, because what you were not gotten to yet about the label is that in those who are interferon intolerant, which was not defined strictly, could then get 24 weeks of Sofosbuvir. And so this gives us the opportunity to say, people who have been treated before or know they couldn't possibly take interferon, we now have a good guide to say, you've got about a 3/4 chance, if you're at least similar to the patients in the clinical trial and healthy, of a cure, which is pretty attractive. Otherwise, it was the 12-week of interferon-free for genotype 2 and genotype 3. And this is actually where we learned the genotype 3 for 12 weeks was just not that effective. And so only about not quite 2/3. And this is where we learned in subsequent trials where you had to treat genotype 3, which strangely then people say the new genotype 1. That is the cranky one compared to 2 and 3 probably should no longer be put together because they are so different with these potent drugs. And so we know that it was 90+%, really expected 90% SVR for 12 weeks in our HIV infected patients. So this is just super.
So, the Photon trial, just to summarize what you just said, because you hit all the points that are important to know, was very interesting, because this is the only study, phase 3, that they used an interferon-free regimen in patients with genotype 1, the only phase 3 study. And they did use the Sofosbuvir and ribavirin for 24 weeks in this population, and they had very reasonable sustained response rates, not 90%, which we didn't mention already, but in the mono-infected patients with genotype 1, Pegylated interferon, ribavirin, and Sofosbuvir for 12 weeks had sustained response rates of approximately 90%. Not 90% here with this 24-week interferon-free regimen, but it was 76%. Certainly a robust response.
I wanted to make a point right there about how we are thinking about this as 76% being okay with this drug, it's about drug resistance. And that something that we haven't mentioned is that the hep C protease inhibitor, the genetic barrier to drug resistance is very low.
Yes.
And while they were potent drugs, basically it's a race between how fast you can get suppressed and the emergence of resistance. And so the patients who fail because they really don't get undetectable and they get drug resistance. And that drug resistance, while it's not archived, really sticks around for a couple of years. And, some a little shorter, but some longer. Sofosbuvir appears to be really different from that. That while there is a resistance mutation described, this so far has not resulted in treatment failure in any, or I could say perhaps one out of the approximately 1,500 patients who've been in these clinical trials. Therefore, this can be recycled. Where the protease inhibitors, if you get resistance to one, just like the HIV drugs, you got resistance to the others. And while in the long-term matter, we're really talking short-term here where things are changing over a couple-year basis. And so I think we're not saying, oh, you could just give a hep C protease inhibitor and not worry about a 75% response rate. I think that one of the things is, well, that's pretty good. You have then patients, you have a quarter of patients with drug resistance, or maybe 15 to 20% with drug resistance. Can't recycle that drug. But sofosbuvir, we give it for 6 months, it doesn't work. We could use it again in a later regimen with other drugs, and we'll come to that. So I just wanted to put that in there at this point.
So on label now, if you were to adhere to the approval indications, an option would be to treat the HCV HIV co-infected patient with, if they have genotype 1 or 4, with PEG, Riba, and Sofosbuvir for 12 weeks and 12 weeks only, or to treat the genotype 2 patient with Sofosbuvir and Ribavirin for 12 weeks only, or to treat the genotype 3 patient with Sofosbuvir and Ribavirin only, but for 24 weeks. Now, the infectious disease healthcare providers, better than anybody in terms of taking care of hepatitis C, understand the possible benefits of combining medications with different classes that are direct-acting antiviral agents. Now, that has not been done yet in a phase 3 trial that's been published, but there is a phase 2 trial that's ongoing that is looking at combination of the 2 drugs that were recently approved, Sofosbuvir in the protease inhibitor category and Sofosbuvir in the polymerase inhibitor category. This study is called the Kosmos Trial. Again, it is ongoing. It hasn't been completed yet. It will soon be. But Daniel, do you want to comment on some of the preliminary results? Because they're actually very exciting.
Yeah, it was very exciting results and a little bit surprising. It just sort of came out of nowhere almost, and all of a sudden what we had is a single tablet of Sofosbuvir and a single tablet of Sofosbuvir, throw in some Ribavirin, taken for 12 weeks, and we had an SVR rate of better than 90%. And in fact, if you had genotype 1b, it was basically 100%. And in the 1As, if you had, this is a little bit of a for the aficionados, but there's a polymorphism of the genotype 1A, where if you had this particular polymorphism at the position 80, then your response rate was a little lower. But if you didn't have that polymorphism, it was essentially 100%. Now, not large numbers in the study, but such a simple regimen, 12 weeks for 95%. Think of it, the cure rate is fantastic.
Is very exciting, and this is for genotype 1 patients, and the exciting part about it is, Sofosbuvir is 1 pill a day, and Sofosbuvir is 1 pill a day, and the study actually looked, again, it was done in 2 cohorts. One cohort, they looked at treatment-naive patients, another one with or treatment-experienced patients with minimal fibrosis, and the other cohort, they looked at patients that were treatment-experienced and had advanced fibrosis. They were kind of a wide variety of patients, and they used with and without Ribavirin, and they used 12 or 24 weeks. And what they really found was, in this small number of patients, that 12 weeks versus 24 didn't matter, and Ribavirin actually didn't matter either here. Now, and again, preliminary, but SVR 12 rates that were reported in cohort 1 and SVR 4 rates in cohort 2 have been reported. And as you said, the SVR rates are over 90%. Tolerability outstanding. What about the issues with the drug-drug interactions?
Right.
Because you still have Sofosbuvir.
Right. So this is going to be a problem in their HIV-infected patients, although it's so attractive that, again, it gets you back to thinking, who could switch? Because of, we had some people with advanced liver disease in this. And perhaps we could just say, for a moment, talk about tying in our cirrhosis issue, because one of the things to consider is that patients with cirrhosis, giving them interferon can be dangerous. They can decompensate. We don't know for sure that that's not going to happen without it in the direct-acting agents, but one could suppose and consider that this might be safer, actually, to do with your cirrhotic. So identify that they're cirrhotic and consider that this might be a good idea.
So again, the caveat being, not just that it's not approved for this, but the number of patients treated are relatively small, not insignificant. I think it's in the 80 patient range in the two cohorts, but not a huge number of patients. And then there's a caveat with third-party payers paying for an off FDA approval indication. But there will be some buzz about off-label combining Sofosbuvir and Sofosbuvir for treatment of mono-infected patients and in the appropriate HCV HIV co-infected patients. At Mount Sinai, do you plan on embarking on such a plan, or are you going to kind of stick with the Sofosbuvir itself as a direct-acting antiviral agent?
Well, the way I'm thinking about it, my colleagues, is this: that if we have even better things coming, which we will tell you about in a minute, but so for people who have stage 3 or 4 fibrosis now, we really want to get treated now. We make them the top priority, and if we can get them the Sofosbuvir, Sofosbuvir, that is the goal. And interestingly enough, as an early read, at least with the commercial insurance, Sofosbuvir is a little cheaper than Sofosbuvir, and that 24 weeks of Sofosbuvir costs them more than 12 weeks of Sofosbuvir or Sofosbuvir. And we've had insurance companies, one called me up and asked me, would you please use that combination, not the twice as long one already? So actually, the wonderful thing about it is it's going to be more effective for genotype 1, probably 90+% compared to 76%, and actually a little bit cheaper. And so the commercial insurance companies, I think, want that. So that's whom we're going to aim for. And I think those people, I'd look very carefully in their HIV infection. Can we change their antiretrovirals to something? Again, you're really looking at just the integrase inhibitors and rilpivirine, pretty restrictive. Other than that, many of these people are interferon intolerant, and the people who really need to be treated, I want to get them on Sofosbuvir now, and we'll treat them for 6 months. And so that's sort of the general breakdown, and then continuing to warehouse people who have very little fibrosis toward what we're seeing as an emerging, even more effective all-oral regimen.
Well, it's great. So it seems for this formerly difficult to treat patient population, the HCV HIV co-infected patient, we now have treatment options that are highly efficacious and relatively well tolerated for treatment, and we have that now. More things are coming, and we're going to discuss that in segment 3. This ends segment 2 in the Investigator Insights in HCV CME program, where we discussed current treatment options. Please stay tuned for segment 3, where we discuss future treatment options for the HCV HIV co-infected population.